Hello, everybody, and welcome. This is the first Ifso Apc seminar, and I'm very, very thankful that someone who's taught most of us in Asia Pacific, Professor Vijay Lee from Minsheng Hospital, Taiwan, is here to give us a talk on microvascular complications with metabolic surgery. All right. Um, do they help? Do they not help? So at the end of this lecture, please type in your questions and Professor Lee will be able to answer most of those questions. Professor Lee, thank you once again for this opportunity to hear you. And for all those people who have not logged in, remember that this program is recorded. So all your friends who missed out, please tell them they can log on to the Ifso APC website and listen into this program. Thank you, Professor Lee.
Thank you, Murphy. And hello, everybody. I'm Vijay Lee. It's really an honor to participate in the first APC webinar. And I would also like the Manula to do all the logistics. And thank you, Murphy, for the invitation again. So since this is an APC seminar, so I'm thinking about the topic. And I think about the technical part, then I think maybe we should start something important and specific for our region. So I choose this topic. So I will start my presentation here. So the topic is metabolic surgery reduce cardiovascular risk in obese diabetes patients. As shown in this figure, you can see this is now the daily practice of our center. A lady BMI 32.8 with poorly controlled diabetes, infertility. Then have a bypass surgery 5 years later. We can see he still had complete remission of the diabetes and with a very good family. So what's behind this? I will talk about. So the outline today is I will talk about bariatric surgery and the cardiovascular disease. Then we'll look at the metabolic surgery. Then the last is then what? So by definition, we need to clarify. Bariatric surgery, I think we are mentioned for morbid obesity. And we are doing all the comorbidity with those with BMI more than 35. And it's a treatment, weight reducing surgery for obesity. We all know the most highest prevalence influence area is around the American United States. Asian in this part is always not so severe obesity as the Western country. So the color is only light yellow in this region, except the Australian. Although the incidence is increasing in Asia, this is a statistics we done in Taiwan in past 20 years. The incidence of morbid obesity, that's BMI more than 35, increased from 0.4%, now is 1.4%. So it's not a small number, but comparing to the Western side, it's still not only about 1 of 5 of the incidence. I think the situation is probably quite similar in all the Asian countries. And for this group of patients, we all know they had an increase of deaths. And the increase of deaths, the cost we can see is increased linearly with the increase of BMI. And significant, we can see all the cause of death is around the cardiovascular disease. So we must understand for this group of the patient, although they had some increase of the cancer, diabetes, but the cause of death related to BMI is cardiovascular disease. So this is probably the #1 target we need to look at the outcome. So for those more than 35, the cardiovascular disease, coronary, especially coronary heart disease or heart failure or cardiac arrhythmia, is all comparing higher along with the BMI. And bariatric surgery, we know, is the most durable, effective treatment for morbid obesity. By blocking this coronary risk factor and the cardiac structure, improve the cardiac function and also the outcome, we really can theoretically cut the incidence of myocardial infarction and stroke and heart failure. So decrease the cardiac mortality. So this is the pathophysiology and the theory. Then we look at the evidence. Yes, we now have enough evidence to showing bariatric surgery can decrease the mortality of morbid obese patients. This figure, I think you are all familiar with SOS study. So the decrease starts from around 8 years and become more and more with the longer follow-up. And the decrease of this mortality is majorly related to coronary events and cancers. So by this statistics, it's around 30% reduction of the mortality. And they later published, SOS study published the specific analysis for the cardiovascular disease. And you can see they had more reduction in the mortality of cardiovascular disease. And for cardiovascular event, they also have a significant reduction. But I think the most significant reduction is on reduce of the mortality. So this long-term follow-up and larger scale provide the evidence bariatric surgery do reduce the cardiovascular mortality in this group of patients. And when diabetes involved inside, I think the situation will be more severe because we can see there's more blood lipid accumulation in the blood vessel and also the inflammation induced by the diabetes states. So from prebiotics to diabetes associated with insulin resistance, this kind of process will aggravate the atherosclerosis of the vessel, then cause of the cardiovascular accident. So this kind of cardiovascular disease outcome is associated with the glycemia control. So this figure to show is if the diabetes is controlled better in remission, then you will reduce the cardiovascular risk in this group of patients. So in morbid patients, if they associate with diabetes, the risk of CVD disease will increase. However, if we can provide a better glycemia control, we can reduce the risk again. And about the procedure, it's quite interesting because most of the data coming from root gastric bypass, they don't have much data about the new procedure, sleeve gastrectomy. I can find this newly published paper. They look at the different procedure and they don't have a real solid outcome. So they use the Framingham score to predict the risk. So you can see after surgery, the risk is decreasing. And if you analyze subgroup of different procedure, the absolute reduction you can see is more significant in the lower gastric bypass or sleeve, better than the adjusted gastric band. The reduction in sleeve and the lower gastric bypass is quite similar between these two procedures. So in morbid obesity patient, the sleeve had the same efficacy as lower gastric bypass in weight reduction as well as in CVD risk reduction. This is the paper telling us. And the risk reduction is around 40%. I think we can remember this figure is similar to the data from SOS study. So for bariatric surgery for morbid obesity, we can expect a 40% reduction of CVD risk. Then recently, there are more papers coming from the morbid obesity with diabetes patient. In this group of patients, I think a reduction will be more significant. So in this paper, it's showing the reduction of the CV deaths in morbid obesity patient with diabetes. The reduction risk is around 50%. They follow for 3.5 years, already see a 50% CV death reduction. This paper is to showing the absolute reduction. The mortality rate is from 5.8% at 5 years to 1.8% at 5 years. And bypass is more effective than bending. So this also supports a 50% more reduction in morbid obesity with diabetes. And the paper we just present is to showing in this group of patients, probably sleep had a similar effect as gastric bypass. This is a recent published paper. So in the first part, we can make a conclusion. Bariatric surgery is effective for morbid obesity patients and reduce cardiovascular disease in this group of patients, especially when they combine the diabetes. And procedure itself, sleep has an equal effect as the gastric bypass. Then we need to look at the metabolic surgery. By definition, metabolic surgery, I think, is for those with BMI less than 35. And specific now is for diabetes. We all know diabetes is a major health issue now in the worldwide, and 60% of diabetes is from this region. So you can see in the Asia region, they are all severe involved the diabetes. And the problem for Asian, I think, we have a more metabolic surgery than bariatric surgery. If we see the diabetes patient distribution according to BMI, so there's probably less than 2%, we can call it bariatric surgery. The other 98% of those belong to metabolic surgery. However, at the current indication, as we see BMI 27.5, it only consists of about 20% of all the diabetes patients, probably candidate. So, do we have the evidence from metabolic surgery to support metabolic surgery can reduce cardiovascular disease? I don't think the evidence is enough now because metabolic surgery is quite new. Metabolic surgery, we all know, is start from Rubino's landmark study published in 2006. So it's about 10 years ago. We have the metabolic surgery coming out. And of course, in this decade, we now have a very good progress. And we have the guideline from the IDF to showing of this kind of treatment can be provided in Asia with BMI more than 27.5. And also from the ADA, I think from 2016, metabolic surgery was incorporated in a treatment algorithm for the obese diabetes patient. And all this guideline coming out is from randomized trial. We now have probably more than 10 randomized trials look at the metabolic surgery. And there's some randomized trial already have 5 years result. They all showing a better glycemic control in surgery versus medical. However, this is showing only the medical control, and none of this trial can show a survival benefit in metabolic surgery up to now. For example, we had want to look at the solid outcome in this study. In this study, we use a medical match control group in one of our medical study. So in this study, we recruit about 800 medical person group in here, comparing to a surgical group. And for the 5 years data, you can see surgical had a better glycemic control than the medical group. However, the medical group still maintain the HbA1c through the 5 years. So it's another bad medical treatment. It's a quite updated medical treatment to maintain the A1c in 5 years. And this is probably because the surgical provide a durable weight reduction in this group of patients. And comparing to the matched medical group, you can see the BMI remain the same, although it's a little decrease in here, but it's not enough to provide a better glycemic control. But we look at the solid outcome. Comparing to the knowledge we had just learned from the morbid obesity, it's not very surprising. Even follow up for 5 years, we really not see a difference in mortality. There's 1.9% in the surgical group. In the medical group, 3%. It's not significant. And for the end-stage renal disease, it's not significant yet. So the conclusion is there. Although metabolic surgery provides a better glycemic control at 5 years, but there's no difference in the mortality rate between the two groups. So in order to resolve this problem, so we launched the Taiwan diabetes study. I would like to introduce is we recruit 1,000 patients. We intend to follow 10 years to look at the solid outcome of the diabetes. However, you can look at, we screen around 30,000 patients, and only 4% they are fit for our inclusion criteria. So in a true world, there's only 4% in our screening diabetes patient is candidate for metabolic surgery. It's not very high. I think most of them is because the exclusion criteria. They are either too old or the BMI is too low. Otherwise, is the function is not good enough. So after the first stage screen, we go into laboratory. We need to exclude some patient again because the renal function impairment or the C-peptide is lower than 1. So the truth is, after 3 years, we finally recruit 1,000 patients. And in this 1,000 patients, up to now, 126, they received the surgery, and the other maintained in our medical arm. Of course, the surgical patient, they tend to have younger, higher BMI, short duration. But we will analyze in the later. This is the data now we have. And we now follow up to 4 years, I think. And the glycemia control, as the randomized trial showing, is of course a better glycemia control and weight reduction in the surgical group compared to a medical group. But to the 4 years, we don't see much difference at this moment, either the mortality or the end-stage renal disease or acute AMI episode. Although there's more instance in medical therapy, but still happen in the surgery group, especially in the first several years. So we intend to follow up longer period, up to 10 years. We hope to see the real benefit of metabolic surgery on reduce the mortality of this group of patients. However, before that, we can use some score system to evaluate the reduction of the risk and comparing the procedure. So this is what we are going to present today, is our new online paper we look at the metabolic surgery and influence of different surgical procedure. So it's quite interesting to look at how do our medical colleagues to evaluate the risk of CVD. This is a very famous for diabetes. This is a UKPD from the UK system. They designed this UKPD scoring system and had been external validated many times. This engine system evaluation 10 factors. So you can see there are 5 patient factors. It's not influenced by clinical treatment. One is atrial fibrillation, and there's a 5 factor we can manipulate, not including smoking, A1C, systemic blood pressure, total cholesterol, and high-density lipoprotein. So use this UKPD scoring system, we can predict the 10-year risk of cardiovascular disease as well as the stroke instance. So this is the data we evaluation in our cohort. So in this group of patients, the 1-year diabetes remission is 76% for complete remission, and for partial remission include is 86%. Is a not bad result. And most of the risk we just mentioned in the UKPD system, there's a 4 measurable is systemic pressure, A1C, total cholesterol, high-density lipid protein. They all significant decrease in the study. So then we can see the absolute reduction percentage for this group of patients. So the overall is 392 metabolic surgical patients. So after 1 year surgery, there's around 50% reduction in the coronary heart disease, as well as the fatal coronary heart disease. So this is really corroborate with the data from the bariatric surgery. And when we divide it into the metabolic surgery, 144 patients, and morbid obesity bariatric surgery, 248 patients, we can see the reduction, absolute reduction for coronary artery disease and the fatal coronary artery disease is quite similar between these two. So the reduction efficacy is similar in metabolic surgery as well as the bariatric surgery. But we also need to see there's no significant reduction in the stroke instance. Quite interesting in why there's no reduction of the stroke instance, because I think the reduction is minimal, but there's one significance in the fatal stroke in the metabolic surgery in this 20% reduction. This is only, we can see significant only in here, but not in here. So I will explain later the policy and the reason for this. Then we look at the different procedure. We compare the sleeve procedure and the Roux bypass and the mini single osmosis or one osmosis bypass. You can see the factor most important difference is the HbA1c reduction. There's a higher reduction in the one osmosis compared to Roux and Y, and both of them are better than sleeve. So let's make a difference in the diabetes remission. There's always high remission rate in a single osmosis or the one osmosis gastric bypass, and the Roux is always quite similar to the sleeve. And this is to look at the absolute reduction in different procedure. So by this comparison, you can see in sleeve gastrectomy, the reduction is around 38 to 33% for both coronary heart disease and the fatal instance. But for Roux gastric bypass is approaching to 50%, and fatal is 55%. And for the one osmosis, single osmosis, you can see the reduction is all above 50%. So by this, you can see the metabolic surgery, the coronary vascular disease risk is reduced more in bypass procedure comparing to the sleep. And we do a multivariate analysis, and it's showing sleep is a negative predictor for the reduction of CVD risk. So for this study, I think you can see the handout we provide in a webinar. So the conclusion for this study is, first, we can see for diabetes control, bariatric surgery or metabolic surgery can provide a 76% complete remission, 86% partial remission in 1 year. And the 10 years coronary heart rate disease risk reduction, we can see it's from 8.8% to 4.6%. And for the fatal coronary heart disease risk, it's decreased from 4.6 to 2.1%, about 50% reduction. And a similar CVD reduction was seen in both in bariatric surgery group as well as metabolic surgery for those with BMI less than 35. However, no reduction in stroke instance. My thinking is due to the inadequate reduction of blood pressure. And multivariate analysis confirmed in metabolic surgery, sleep itself is a negative independent predictor of CVD risk reduction after metabolic surgery. I think this is the most important finding we see in metabolic surgery comparing to the bariatric surgery we had presented in the previous literature. They all show similar efficacy between sleep and for bypass. But in metabolic surgery, we see it's a negative independent predictor. So the last few slides, then what? If we know these things, I think that's from our clinical practice to see. This is a patient we see in our outpatient clinic, BMI 32.6, come for the mastitis. So in this unmarried lady with huge mastitis, we need to think about diabetes, especially in Asia. So we check the status and disclose she is an undiagnosed diabetes patient. A1C is 13, very high blood pressure, blood glucose, and good C-peptide, beta cell. So we treat the mastitis and start medical treatment, and we can expect after 6 months she still have a very poorly controlled diabetes. So we provide a metabolic surgery, that is one osmosis bypass. And up to now, I think it's already 3 years, she still maintained in complete remission of the diabetes. But what should we do for this patient? We had to provide her a better glycemia control, but do we really reduce the long-term mortality of her? And we must say we don't have the evidence now. So what we should do now, I think, is we still need to follow up the patient, especially provide a glycemia control by lifestyle modification of the patient to prevent the recurrence of diabetes. And the second, if the patient has smoking, we need to strongly advise quit smoking, because this is one of the indicator used in UKPD risk engine. And the third, of course, we need to continue control the blood lipid if patients still had hyperlipidemia. But most of them will have a normal lipid after bypass surgery. So let's say it's only one thing we need to look at is our experience is most of them still have some blood pressure. We need to control the blood pressure. I think it's the most important thing we can do now. And this is both in further reduction of the cardiovascular risk as well as the decrease of stroke risk. because the occurrence of this stroke probably relate to blood pressure. This is a very important factor. So we come to the last slide, is take-home message. So we can see in this region, in past 2 decades, I think bariatric surgery is growing very fast in this region. And now it's pretty mature in Asia. We can see the statistic in Asia region. We now have more than 40,000 cases a year in this region. And in 1 decade, I think metabolic surgery is also become a standard treatment now for type 2 diabetes with obesity in this region. And we can say metabolic surgery reduce cardiovascular region in patients with type 2 diabetes as well as bariatric surgery. That is, according to our newly published paper, we can see from the UKPD risk engine, the risk reduction is quite similar we see in the bariatric surgery. However, we need more data, especially solid outcome data. And one is data of young onset diabetes. I don't have time to mention this, but I think this is also a very important issue in Asia. Then for this moment, I will suggest you, for your patient, to continue follow up your patient and treat your patients, especially the blood pressure. I think it's the most important thing probably we can do now. So thank you very much. This is my presentation for you.
Thank you, Professor Lee.
Hi.
Thank you for this great talk. And just for everybody, if you have any questions, please type them out so that I can ask Professor Lee to answer these questions for you. Yeah. Kazu's question, Professor Lee, is remission of type 2 diabetes is higher in SAGB than in Roux-en-Y, and Roux-en-Y and SG are almost same. Why Roux-en-Y same as SAGB regarding cardiovascular risk and superior to SG?
Yes. So I think this is a great question. So
Kazu is awake.
Data is data. So I must say, in bariatric surgery, randomized data showing is really very compatible between the sleep and RIGB. But still there's some difference. Some studies showing a 5% or 10% difference. So my explanation is for morbid obese patient, weight reduction probably is the most important factor. And since both sleeve and the rural gastric bypass provide equal level of weight loss, so we don't see much difference. And for the theory we all know the most important mechanism for the bariatric surgery is restriction, followed by some gut hormone change. So if we look at these 2 procedures, both procedures had a restriction, and sleep also have many gut hormone change, especially the GLP-2, GLP-1. So the role of duodenal exclusion in our previous study probably only play about 5% of 10% efficacy. So probably not very important in morbid obese patient. Yes, but in low BMI patient, usually they don't lose so much weight comparing to morbid obese patient. So that increase the importance of other mechanism. For example, the duodenal exclusion. So that is only my guess. I don't have a really good explanation. Yes. How about your thinking, Murphy?
I think, Professor Lee, what this has probably told us is that though weight loss and everything else is not as relevant, the most important thing is probably duodenal exclusion and the exclusion of the proximal part of the jejunum. which probably tells us why SHEP and RUMI have the same risk profile, because it decreases HDL, it decreases cholesterol, it decreases um, other type 2 diabetes much better than the sleeve. And that's why I believe in a sleeve gastrectomy, you do not get variation in the cholesterol level or the LDL and HDL levels. Do you believe that is true?
Yes.
I have another question for you, Professor Lee. There's another question. I'll first ask you this question. Where biliopancreatic and lipid control, where BP and lipid control better in RUMI and SAGP than sleeve gastrectomy in your study? Were hypertension and lipid control better in RUMI and SAGP than sleeve gastrectomy in your study?
You mean the blood pressure control?
And lipid control.
Lipid control, I think the data is showing bypass is much better than the sleeve, especially in the LDL. But for blood pressure, we don't see so many difference. I think it's quite complicated for the blood pressure mechanism. And if you look at the data, sleeve have a very good blood pressure control in morbid obese patients. And the efficacy is quite similar to gastric bypass. But in low BMI patient, we don't see difference. And we see a little better in gastric bypass than sleeve. However, it's still not adequate. The remission rate of blood pressure in those low BMI patients is always around 50%. The other 50% still have hypertension. Yes. So I think we need to stress the blood pressure control in this group of patients. Otherwise, we probably will not reduce the risk of stroke in this group of patients. Yes.
Professor Lee, I wanted to ask Kazu and Seki, both are on this group, one question. You all have compared sleeve versus sleeve with DJB. You all see any difference in control of lipids or in controls of BP? So you can type your answer whilst I ask Professor Lee another question. Professor Lee, in one of the slides in surgical endoscopy, you showed that the reduction in rate is equal with the sleeve and with the gastric bypass, correct? But as compared to gastric banding, it was 3.07,
Yes.
and revision surgery was 3.68. So why is that? Does revision surgery not reduce cardiovascular mortality, according to that paper? Because
Oh,
they were the same numbers.
I think because revision surgery, they already have some weight loss on the previous operation. So in revision surgery, where you compare the reduction of the risk, I think it's not fair. So the reduction, of course, is not comparable with the primary surgery itself. Yes. Do you get me?
Yeah. Mr. Lee, there's another question. Considering stroke and cardiovascular disease have similar risk factors related to metabolic syndrome, is there any plausible explanation for the non-significant reduction in the risk for strokes after metabolic surgery? This is from Harsh. Uh, I think Professor Lee probably answered that question, Harsh. He said that BP control is not as good, and probably that's why he feels that stroke is probably not as good. Is that correct, Professor Lee?
Yes, yes. It's also very new for me because before I doing this evaluation, I really don't realize we really don't reduce the stroke instance. But when you look detail, even in bariatric surgery study, there's no significant reduction in the stroke reduction. So it's quite interesting for me. And when I look at the data, we can see probably the only factor we are not controlling well is blood pressure. There's no problem in lipid. In the lipid, we have already very low lipid, and we can add some medication even. But I think we probably neglect a little higher hypertension. So we don't give enough medication for them. This is my thinking. Another possible is in Asia, uric acid maybe also play a role, because there's not many paper to look at the uric acid, and we see quite often our patients have hyperuricemia even after surgery. Yes. So
Professor Lee, Federica Garcia said, for blood pressure control is more important diet quality and post-op long term, or more medications. So do you think diet control is more important or medication for blood pressure control?
that means we need to add medication after surgery if they still cannot reach a good blood pressure control. For example, usually the patient before surgery, they probably have a 160 systolic pressure. Then after surgery, they may decrease to 140 something. And we think it's enough, so we stop give medication. But I think this is not enough. For this patient, we still need to control the blood pressure under 120. So we need to give some medication for the blood pressure control. Yes.
So the question I had asked Kasama whether sleep versus sleep DJB, he says that DJB has better control, at least as far as LDL and diabetes goes.
Comparing to sleep, of course.
Yes. So,
Comparing to gastric bypass is quite similar, I think.
yes. And Seki wants an opinion from you, Professor Lee. Young onset type 2 diabetes is a serious problem, especially in Asia, and is often resistant to conventional medical therapy. However,
Yes.
based on the ABCD score theory that you've proposed, the efficacy of bariatric stroke metabolic surgery seems more effective in the young onset than in the late onset.
Yes.
Is this a speculation of mine? Is it correct or is it wrong? What's your opinion?
I think we need to think from another point. We don't know how long we can control diabetes in this young onset patient, but still, if we can delay the control for 10 years or 20 years, that may be very helpful for this group of patients. But we don't have data now. So I think the most important is in this region, we probably need to launch a multi-industry, multi-country to look at this specific group of patients. Yes, young onset diabetes. And my personally recommend we can do this surgery for young onset diabetes even in a little lower BMI, but we need to do earlier. Then we follow the patient to see the long-term outcome. Yes.
Professor Lee, Enrique Arayas from El Salvador says that why do you think Asian patients have better diabetes control after metabolic surgery with lower BMI as compared to other regions patients?
I think it's because of the ethic, because we are very sensitive to diabetes, so the risk increase even BMI more than 22 in India. In I think in Chinese or Northeast Asia, the risk will increase when BMI more than 24. So of course, if you bring a BMI 30 going down to 24, you have a huge reduction of the risk of diabetes happening. But if you use in a Caucasian patient, this is not the story. If you bring a Caucasian BMI 30, you down to 26. I think the efficacy and the risk reduction is not comparable with the Asian. This is ethic difference. Yes.
So, any further questions anybody has? So I think Professor Lee has really stirred the honestness out over here. He's shown us that metabolic surgery, stroke bariatric surgery works equally well in low BMI, below 35 versus high BMI. It's the same. He's shown us that cardiovascular risk and fatal cardiovascular risk does come down. However, stroke probably is debatable. We don't yet know whether it is just the blood pressure control and whether uric acid control, which is relating to stroke risk coming down. The other thing we've noticed is that despite these factors, we will, for the next topic, just to cover up on this, we will talk also about um, a decrease in endovascular endothelial factors, so kidney disease, Professor Lee, or whether uh, non-alcoholic steatohepatitis and other factors, or whether diabetic retinopathy or nephropathy uh, uh, or neuropathy can come down. What is your opinion on that? Other micro and macrovascular diseases. What's your opinion on that?
Yes, but we, as I mentioned, metabolic surgery is only 1 decade in Asia. So when we need to look at the outcome, I think the major cardiovascular disease probably is the first thing we can see. For the microvascular, like you mentioned, the renal disease or the eye disease or amputation something, I think we need even longer time to follow up. So at this moment, I just want to mention for a major risk for cardiovascular disease, because you look at the data from the bariatric group, they can see difference only follow up 3.5 years, and they can showing a significant reduction in the cardiovascular disease in that group of patients. So but when we look at the low BMI metabolic surgery, I think the patient group is different. And we must say up to 5 years, we don't see really different solid outcome. Although we now use the score system, we can predict a reduction in 10 years. But it is an interesting we look at. And for microvascular disease, I think we can see difference, but we probably need to see different population as in young onset diabetes patient, because that group of patient is very high risk, I think, in renal disease, but still they need maybe 15 years or 20 years to showing the difference by metabolic surgery. So, and for the other disease like the NASH or other disease, I think is probably not relate to direct mortality deaths so clearly. So we need more number of the patient to showing the efficacy in reduce the mortality from the NASH. Otherwise, we have enough evidence to showing resolution of the NASH, but there's nothing about mortality. Yes. So that is my thinking.
Professor Lee, in one of the slides in your presentation, you did show that overall mortality does not change, though the cardiovascular risk factors does come down. But in general population studies like Ted Adams' paper, in Flum, Dellinger, in Christou's paper, they've generally shown that if obesity comes down and if diabetes comes down, overall chance of living increases. So what is your take on that? There is a difference. And you are doing your own study, but 4 years, there's not much of a difference. So maybe at 10 years and beyond.
Yes. I think this kind of study, you definitely need a larger number of follow-up. You can see those papers, they at least have 4,000 or 5,000 patients. Otherwise, it's not easy to look at to see the outcome. So for one center, it's probably very difficult to get enough patient number to see this kind of outcome. Yes.
So you need general population studies.
Yes.
Well, any further questions you'll have for Professor Lee? If not, I think what we'll do is we'll thank Professor Lee. Thank you very much, Professor Lee, for sparing your time and staying up so late. And for my friends from Japan, Kazu and Seki, thank you so much for staying up till so late. Um, we will continue the Ifso APC webinar series. We'll come in January next. And please keep watching and please ask your friends to join in. Thank you so much.
So we also need to thank you, Murphy. Your successful first webinar in Ifso Apc and also in the first webinar seminar in Oral Society of Asia. Thank you. Congratulations, Murphy. Thank you.
Thank you. Thank you. Thank you, everybody, for joining in. Bye-bye. Bye.
Bye-bye.